If you look at the classification of heart failure these days, there is a newer entity that has come up after the usage of ARNI, that is heart failure with improved ejection fraction. Now this entity means a patient who had heart failure with reduced ejection fraction or EF less than 40%, and with guideline based therapy including ARNI, if the ejection fraction increases to more than 40, so the patients go into a newer class of classification, that is heart failure with improved ejection fraction. Now, do this class requires a different treatment as compared to HFrEF? So my answer would be no. We have to continue with the the guideline based therapy even if the patient's ejection fraction improves, because if at all we reduce the dose of or we stop ARNI in such clinical scenario, or for that matter other anti-heart failure therapy, there is high probability that patients will again land up into heart failure with reduced ejection fraction. So naturally, if the patient's ejection fraction is improved, we see to it that we maintain the guideline based therapy. The only modification that is required is we can reduce the dose of loop diuretics and consider to stop it altogether, because we all know that loop diuretics do not have any mortality benefit. Other molecules we need to continue in the optimum doses and has to be continued with regular follow-up, so that the benefit that is achieved by the heart failure management are not lost and patient's ejection fraction is maintained in the normal or near normal range.